Welcome to SARC Talk. SARC is a nonprofit cancer research organization that develops and manages clinical research trials in pediatric and adult sarcomas. SARC Talk is a podcast to discuss activities of SARC, interview sarcoma research leaders, and review scientific initiatives in the sarcoma field.
Welcome to SARC Talk, episode number 12. My name is Scott Okuno, medical oncologist at Mayo Clinic and Chief Medical Officer of SARC. All episodes are posted on our website, Spotify, and YouTube SARC channel, and wherever podcasts are available. Please subscribe and submit comments because we do look at them. It is my pleasure today to have Dr. Damon Reed as our guest here on SARC Talk. Dr. Reed is a division head at Pediatric Solid Tumor and Chief of Pediatric Sarcoma Service at Memorial Sloan Cancer Center. He did his medical school at Case Western. He did his residency in pediatrics at Boston Children's. He then went and did his fellowship at St. Jude's, and then he had his major part of his career till now at the Moffitt Cancer Center, and then he is now presently at Memorial Sloan Cancer Center. At Moffitt, he was the chair of the Department of Individual Cancer Management and director of the AYA program, and he's now in the last 3 months, is that correct, Dr. Reed, over at Memorial Sloan Cancer Center. So welcome, Dr. Reed.
Thank you so much. Yes, that's perfectly correct. Thank you so much for that nice introduction.
We are very fortunate to have Dr. Reed here, and maybe, Dr. Reed, you can tell our audience a little bit about yourself and how you got interested in pediatrics, because most of the interviewees that we've had here in SARC Talk have been adult oncologists, and then how you got interested in hematology oncology.
Absolutely, yeah. So in entering medical school, I had a guess. I mean, I wrote the standard essay about wanting to help people and all of those things, and absolutely meant and mean it. The two fields that I was interested in medicine were either pediatric oncology, and to me, I didn't know much about the field. I did not have a personal experience with it, but it just felt like such a clear good versus evil kind of field, and it felt like a field where it would get me up out of bed every morning and be very motivated to try to fix a clear assault on human health, that if you could beat the cancer, patients could live forever, like grow to adulthood. So kind of big deal thing. And the other thing was reproductive endocrinology. And so at Case Western Reserve, we had class till noon, and we could sign up for electives afterwards. And the first person I met was Dr. Michael Nieder, who's been a lifelong mentor in pediatric oncology. And it was amazing. And it was like clearly that was the fit. And I kind of knew very early in the first couple months of medical school that that's the direction to go. And then it was solidified by volunteering at a summer camp throughout medical school for children with cancer, and just kind of realizing that it was all that I had envisioned in terms of just a good cause. And it's been a great career. I'm glad I made that decision.
Part of what we've heard from other groups as well is, you go into medical school, know you want to help people, want to do medicine, and you let the things happen, and you had certain people in your career path that kind of influence you quite heavily, and that's the part of the mentorship part, and we'll come back to that a little bit later. But you've done a lot of work in sarcoma, spanning both the adult world, younger adult world, as well as the kid world, in what we would say the AYA aspect. And maybe you can kind of help define what you, as you think about AYA, what it is, and how you see that population being specifically unmet in the sarcoma realm.
Yeah, so coming out of St. Jude and arriving in the Tampa and the St. Pete area, even during the interview process, it was clear to me that there was some strengths of the pediatric hospital, but there was incredible strengths of Moffitt Cancer Center as an adult oncology center. And so the only part of my negotiation coming out of fellowship was that I wanted to spend some time in both places. At Moffitt, it became easy to see 19-year-olds, 20-year-olds, and then that upper limit kept changing. And so before I really knew AYA as a field, I was just seeing patients in their 20s and 30s and sometimes 40s and 50s, but mostly 20s and 30s with cancers like Ewing sarcoma, osteosarcoma, synovial sarcoma, and other cancers that are, classically I think of as pediatric cancers, but can occur beyond pediatric ages. And then was learning about this field that existed called AYA oncology, of taking care of adolescents and young adults, classically defined 15 to 39. So I was more doing AYA than on purpose entering the AYA field. And to say it's spectacular. Like, that age group of patients has all of the same things that appealed to me as a pediatric oncologist. Young people getting cancer, way too early. Families and loved ones and supportive systems around them. And the added benefit of AYA oncology to me personally was there was a lot of plans I would enact on children who didn't have as much of a voice in their plan. I was mostly talking to their parents. And AYA patients would look me directly in the eye and say, "That's a terrible idea." A 27-year-old would tell me, "That has more risk than benefit, doc. That's a terrible idea." And I would say, "Well, I just did that with a 7-year-old in their family, just a day ago." And they were like, "Go back and tell them it's a terrible idea." And I was like, So having the direct consent and risk benefit discussion with the actual patient was what I realized I had kind of maybe strayed away with a little bit as being a pediatric oncologist, and really dealing mostly with the parents. Again, I realized I loved that part of oncology. If I could go back and train, and there was an AYA box, I would pick that over pediatric and medicine. And I think it's allowed me to be kind of accepted in both the medical and pediatric community a bit too, which has been very nice, because I think that there are strengths to both.
No, you're right, and I can just see that most of the AYA world didn't exist in a box, but you just lived it, and now there is this name, and you said 15 to 39, and once you turn 40, you're no longer AYA. I'm just saying, but that is an important aspect, and I think what I'm hearing, Damon, is that when you're seeing patients younger, you're navigating the patient, but mostly their parents. In the AYA world, you are actually having a conversation with somebody who has agency and ability to make decisions on his or herself. Speaking of adult oncologists, we have the old people that they're navigating their kids, trying to make decisions for mom and dad. So it's kind of interesting how we come at a different perspective, and we're all trying to navigate different peoples and keep people together. So I think we can definitely learn from the AYA population, and in sarcoma, specifically the histology and the tumors lend naturally to the AYA world, because the drug therapies and the ability to treat those tumors spot on, the small blue cell tumors, the osteogenic sarcomas fit really nicely. And some of the synovials, as you said, so some of the sarcomas.
Absolutely. Absolutely. And I think that, there are certain times where in sarcomas we have chemo that's accepted as standard of care. It is like, life or death, or there's a clear, huge survival advantage. And the right decision is chemo. There are other times when we're talking to patients about third line therapy or things where it would be unusual if there were 5 family members in the room and everyone felt exactly the same about it. What I do like about AYA and adult medicine is that, when there's that, spouse saying one thing, parent saying another thing, sibling or uncle saying a third thing, and the patient saying another thing. And in AYA oncology, it's clear that, you try your best to get everyone on the same page, but really the person that is the decision maker is the patient. I think it is much harder for parents to make those decisions for their children, and it's a different challenge when I also like to try to work through. But anyway, having the patient as the final decision maker does provide some clarity to exactly what you described, even children being involved in helping their parents navigate these difficult decisions.
No, it's neat. Yeah, we did have Dr. Herbie and Dr. Davis together in a podcast earlier this year as well, and they're both involved with the AYA. So hearing from your standpoint, I hear a different nuance. So this is very unique in ability, and I think there's a gap, because in the adult world, we perceive things differently. In the P's world, you do something differently, but there is this unique opportunity in the 15 to 39 that it is important. So I think this will continue to evolve as a practice, and we look forward to more, studies of this and how we bridge that, especially in sarcoma.
Absolutely.
You've been involved a lot with CTOS, and that's kind of when you and I first started visiting and meeting that. You've been involved with COG. You've been logged with a lot of cooperative group research. Maybe you can share with our audience what lessons you have learned in these various roles. And you can start whatever you want, your role at CTOS, COG, Moffitt, Memorial Sloan Kettering, a little bit early there, but just tell us kind of what you've learned, because we're all learning from each other, and we'd like to hear your story. What's your thoughts?
All right, perfect. Like to weave it all together might be a challenge, but I'm going to try my best. So I would say that, I'll start with CTOS. The Connective Tissue Oncology Society is definitely an organization I'm proud to be current vice president of, and will rise as president, and started as a person in the seats and very excited about attending it. Coming from Moffitt, having a boss that was a surgeon and that person's boss being an orthopedic surgeon, the idea of multidisciplinary teams was not surprising to me. And so when I would go to CTOS, it was just really wonderful to sit down in the same chair within an hour and hear a basic science talk, and a talk about radiation, and a talk about combining chemotherapy, and a talk about surgical outcomes, and either focused around a disease or just a series of themes as we try to tackle this beast that is so heterogeneous, that is sarcoma. And so CTOS has been a wonderful multidisciplinary forum to learn more about sarcoma, learn more about how different people around the world approach it, and to really kind of network with people that have had our shared experience. There is something about being a sarcoma doctor that when you meet another sarcoma doctor, you have this shared experience that is, it just kind of cuts through all the initial part of, awkward small talk. You just kind of feel like a friend, honestly. And so CTOS is fantastic that way, and gives you the full breadth of the people that care about sarcoma and making a difference. And so it's been fantastic for collaborations, for understanding the world approach. And honestly, as a young person, it was fantastic for learning how to navigate and best meet patient needs and through second opinions. And so, we've shared patients in the past, and it's always helpful to have someone as knowledgeable as you and knowing the trials. I've shared people with all over the world, and CTOS has helped to get to the point where when the patient says, boy, this is not a situation I want to be in, can I get a second opinion? I can say, yeah, absolutely. What do you want to know? Like, what do you want to hear? And they say, I want to hear about trials. And I know the 4 people to send to for trials for that aspect if I don't have them open or didn't have them open before. I want to know about, I want someone to talk me out of chemo. And I say, well, here's the places you should go. I want someone to get chemo. Well, here's the places you should go. And then they realize, like, wow, how everyone thinks. And I said, well, not everyone, but yeah, it's a community of people that are working to fight this terrible disease that you have. And I think CTOS is a great forum for that. The Children's Oncology Group has been also a wonderful forum, and there's no way to change the standard of care for pediatric sarcomas, not AYA or adult sarcomas, without cooperative groups. And the Children's Oncology Group will always be the one running the phase 3 studies that try to change the upfront management and relapse regimens for sarcomas. And I do have the privilege of having a good role there to try to fix osteosarcoma and Ewing sarcoma. Similar to kind of the arc of CTOS, it was fun to participate in COG meetings. It was fun to write the first paragraph of like, osteosarcoma is a big challenge and the cure hasn't changed in 3 decades. But now having a leadership role, it's not as fun to write that paragraph because now I'm part of the problem. And so the Children's Oncology Group is a wonderful forum. If we ask any researcher around the country, can you present your work? They say yes. And so you kind of have the gravitas and it's really just the responsibility to make sure the right people are in the room trying to tackle these problems. Moffitt was a fantastic 15 years, and I, fell in love with the idea of targeted therapy, and we're going to find a c-kit on every single sarcoma and a Gleevec that's going to make it better. And then that bubble was, burst early in the career when it wasn't that simple. And then Foundation came out and thought in 2014, well, we're just going to dig deeper and find, drugs or combinations again. That didn't work out so well. I was really thrilled to participate in SARC 28 and be able to give PD-1 inhibitors to patients. And my goodness, patients were batting down the doors to get access to that drug. And while it helped some patients for sure, it wasn't the home run that we were hoping. And so having ridden the targeted therapy and precision medicine and immunotherapy kind of waves of enthusiasm, what Moffitt really did for me when I was a little bit struggling with what is this cancer problem is I got to work with ecologists, mathematicians, mathematical modelers, engineers, this wild group of people that said cancer's not strictly genetic, it's phenotypic. It's a living system that behaves laws of ecology. And I really got into this idea of cancer being an evolutionary event, and that the therapies need to be that way too. And I know we're going to talk more about that, but so that's what Moffitt really gave me, was this the last 5 years of really questioning principles and kind of figuring out if cancer is not a simple thing where we're just one drug away, what is the right way to approach it? And I think that's what I'll always take and continue to work with everyone from Moffitt to try to figure out how to maximize those. And that gets to Memorial Sloan Kettering, and it just is an incredible place where, with tons of trials and really unreal depth and breadth of colleagues that so far, even just in these first 4 months. And I think we are further away from the cure for sarcoma than I wish we were. And I think that's going to take a lot of different steps. And I wanted to try to see if a place like this has some more answers, and really looking forward to turning over every rock here and building teams and the infrastructure to try to tackle cancer as a complex problem as opposed to something that has a simple solution.
Well, Dr. Reed, I just want to make sure you're not the problem. I know you said you're the problem now at COG, but the reality is having people with a broad understanding of what we're trying to do and trying to solve. Yeah, having the same message, there's unmet needs. We need to be thinking smarter, thinking differently about how we approach patient care. And I think what you're saying at Moffitt, your opportunities there allowed you to think about Evolutionary Tumor Board and evolutionary oncology. And I know you guys did a poster or session at CTOS at Vancouver, and maybe you can share with our group here just the concepts of Evolutionary Tumor Board and how that might fit into your realm of pediatric AYA type of thing, because that information may or may not translate into other things, but people just need to know what Evolutionary Tumor Board biology is and how that is different than a regular tumor board. So let's hear kind of what your thoughts are on that.
Perfect. And so this is sometimes difficult, but I'm going to try my best. So I think that one way to think of cancer is that it's a bad cell that keeps copying and pasting itself, and it's one clone, and it's the same problem over and over and over again. And there's just a lot of it, and it misbehaves. That kind of model of cancer, it's fast growing, it doesn't die, it's clonal, exists in the world. There are definitely cancers that have a lot of monotony to them, and that a single therapy is very helpful. Evolutionary Tumor Board would say that the cancer cells, let's just picture the first cancer cell, and when it makes the second cancer cell, that they're different, and they're different in some way. Their genes could be exactly the same, but one could be closer to a blood vessel, and it could therefore get a little bit more nutrients, and it can grow a little bit faster than the other one, even though they're identical. And then they keep fighting with each other, the cancer cells, as they're growing and growing. And we see this with sarcomas. We see a lot of, it's in fact, what helps the radiologist figure out that this is a sarcoma as opposed to a lipoma. They see areas of necrosis on an MRI. They see a lot of heterogeneity in the images. They see areas where tumors are taking up lots of contrast and growing quickly and full of cells, and other areas where it's, again, necrotic or fibrotic or where some experiment was done within that cancer and it just wasn't a successful model and a lot of the cancer cells died. So the evolutionary look at cancer addresses that complexity, says that there is a lot of different sarcoma cells in a tumor. There are a lot of different cells that are competing with each other, exploring different space, working with each other, or building up the infrastructure to kind of grow. And what it really then leads to is, if there is all this difference in the tumor, that what you might do initially to address it, a first round of chemotherapy, the cancer then responds in some way or adapts in some way. So it might be true that someone walks in with a big tumor that's painful and you give a dose of chemo and it both shrinks and the pain goes away. And one could think, that's great, that helped, let's continue to do that forever. But one else also could say that's the traditional model of how we treat sarcoma, and that's the traditional model of cancer. It's a clonal disease, keep killing it, all kinds of hypotheses over the last few decades of hit it hard, hit it fast, maximum tolerated dose, compressed therapy. The evolutionary approach would say, well, what's left is different, and switching therapy would be helpful. And so how it's different is something we still need to work on quite a bit. What to switch to is still something that we have to work on. And so what Evolutionary Tumor Board is a traditional tumor board, radiation oncologists, surgeons, chemo doctors, oncologists like us, radiologists, pathologists, but what also adding mathematical oncologists, mathematical modelers, ecologists, evolutionary biologists, and swaths of other team, preclinical modelers, all sorts of different people, physiologists, to kind of to try to address that changing tumor and trying to predict when and what to change therapy to. That's a summary of Evolutionary Tumor Board. It's trying to anticipate the cancer rather than rely on what is quote unquote working thus far.
This is an important aspect, because when you and I were trained, we thought, kill it, keep on killing it, and do everything forever until it stopped doing it, until it started growing and become visible. And at that time, change therapy. I know in your group down at Moffitt, I think you're probably developing this also at Memorial, you have to have a mathematical model. We have a lot of AI that can help predict when you've reached that sweet spot, when the heterogeneity is starting to change, you've taken care of the cells that responded to the original treatment. When is it appropriate to change, and what do you change to? It sounds easy on paper, but it sounds very rational. And how close are we to knowing when to change, even though it looks like it's still responding? And what are your thoughts on techniques to get to that point?
Yeah, so here's where it's going to be helpful. And thank you. It's fantastic. Here's where it's helpful, I think, to pick a theoretical patient in a disease, because I think if we have if we pick a disease like infantile fibrosarcoma or something that has a target and a very effective therapy, then people would say, why would you change therapy when you have a perfect, a very good therapy with low toxicity that does a good job with the disease? If we have a disease like localized osteosarcoma or Ewing sarcoma, let's go with localized Ewing sarcoma, where that's a good model of where more intense chemotherapy has continued to kind of raise the bar a bit. And those patients are, our last children's oncology group study, 79% do well, like are long-term survival. So that's also not one where I'm saying, let's change therapy in the middle, just, haphazardly. So let's pick a disease like metastatic alveolar rhabdomyosarcoma. This is a disease where when the patient walks into your office, they could have disease all over their body, lumps and bumps, pain, and initially you give that first dose of 1970s chemo of vincristine, actinomycin, and cyclophosphamide, and you expect a rapid shrinking of the tumor and a rapid reduction in symptoms, sometime in the first 4 weeks, but almost for sure. But you also know that the chance of that person surviving the 3 years without a relapse is single digits. In the most recent publication from the Children's Oncology Group also was 6% for that patient. So those kind of diseases where you get a rapid decrease in the symptoms and the cell number and the shrinking of the tumor, metastatic uveal rhabdo, but almost invariable relapse, either during or shortly after stopping that same chemotherapy that you gave for 42 weeks. Those are the kind of diseases that I think are optimal for an evolutionary approach. I call them U-shaped cancers, cancers where you get a rapid shrinking, but almost a certain raise again in what happens to their trajectory. So great response, almost invariable relapse. And that observation, again, wasn't mine alone for sure. There was this huge team of people, and what we realized is, boy, this evolutionary approach isn't for every single patient. We presented some patients in Evolutionary Tumor Board like metastatic osteosarcoma that wasn't responding to chemotherapy, and there really is no evolutionary dynamics. If you don't have any selection, any ability to kill the cancer cells, and the cancer is marching right through primary therapy, there isn't an evolutionary solution to that. You need an evolutionary approach to oncology requires that the therapies you do are absolutely selecting for other cancer cells. But metastatic alveolar rhabdomyosarcoma is one where I don't think we have a standard of care. We have conventional chemo that we give, but that's a place where I do think that there is some emerging data from single cell sequencing from 3 different labs, and it does seem like that story, this idea that the cancer changes, is now being really solidified by excellent preclinical researchers that are showing that the cancer cells are different after that, and they undergo some bottlenecking after the initial systemic chemotherapy that we give.
I appreciate that, because we don't want people leaving this podcast saying we should stop all standard therapy for curative intent. The answer is no. This is a totally specific type of evolutionary biology that you're saying, advanced metastatic disease, for which you get an initial rapid response. And then the real question is it's no longer the same tumor. How do you change and how you pivot? And those are the types of tumors and types of situations that we really often don't get into in the adult world. So just in that part. So how do you see us starting to have the dialogue of changing how our paradigm is in testing this paradigm of Evolutionary Tumor Board? Because none of us are really trained on that. We're trained at work, keep on going, don't stop. So thoughts. You have COG, we have SARC, you have a lot of cooperative groups that we can do. How do you see that moving forward?
I think the general theme is that it's a great question and absolutely the right question. I think that what I'm amazed by in talking to I've got to meet so many different people the last couple months, and it's a shared theme from Moffitt before. I think what almost all clinicians want is to be perfect decision makers. And I think that's exactly what you're asking is for a given patient, like there might be a patient where you feel like there's no way I can cure this patient, but I think I could give them substantial time. And I think I could give them a break from chemo to attend a family member's wedding or to do this or that important event, or I can give them that vacation of their dreams as they're trying to balance, coming to clinic and all that stuff. I think that what you also said earlier, which was if we can assemble the data, and to me that's the not only I was on this chemotherapy for 6 weeks and then I progressed, but actually the images, actually digital pathology when it exists, to kind of get as much clinically annotated serial data and measurements that we could put in a way. We are doing really good at putting genomic information into shareable public databases. But what is woefully absent is what was the chemo that patient was on? How did the 3 lung metastases respond to that chemotherapy? What was the necrosis of them if they were resected? We don't have a lot of sense of the number of cancer cells that we're killing or lying dormant or growing, or how we're modulating those things. And I think that if we could extract all the meaningful data that we take for granted. I mean, we get these CT scans, from the neck to the groin, and we measure single dimensions of 3 lesions, and we say this is how much disease they have, and we throw away all that extra volume data that we could have, and probably some perfusion data and all sorts of things that I know that if we had that data in an organized way, it would attract data scientists, mathematical modelers, and all to kind of really quantify what's going on. It gets to your more pointed question, which is, could you ever envision at the bedside having a tool where you say, this patient's response to gemcitabine and docetaxel is off the charts? Like, what should I do? Should I wait 6 weeks, or is now the time to change to, a tyrosine kinase inhibitor, or now what is the right thing to do? And I think we could only get there with enough data to say, here's how prior patients did, and here's the time where they're starting to fail. The Evolutionary Tumor Board preprint paper that's on medRxiv, shows kind of growth of tumors and shows kind of decision cones and expected responses to therapies. And through a series of kind of evaluations of specific patients based on other patients, it kind of got to the point where the decision was made for a first therapy. This was in a head and neck cancer patient, so not a sarcoma patient, just for that clear caveat. But then now it seems like the patient's response is declining, and now it's time to switch to something else, as we would expect progression if we continue this therapy. But it was based on, a few dozen prior patients and an understanding of what the anticipated response would be for a few different things. So more succinctly, a lot of data and a lot of unable to model what would be expected in a range for a given cancer, and then an understanding of how long and how a population does, and then being able to apply that model to a specific patient to try to maximize their thing, squeeze as much as we can out of chemotherapy, and know when to cut and run to something different.
Yeah, so you're right, because we used to just measure things. We no longer just measure things. You look at the intensity, the Hounsfield units, the necrosis, and now we're to the level of maybe doing some single cell RNA-seq and or biopsies or liquid stuff. So I think we're to the point where we have the technology. We just need a track record of what happens. So then we can plug it in like our circulator tumor, like what happens. But we need all these profiles built out. So I do think there's an opportunity. So when we sit down in a tumor board, evolutionary wise, if you get this response with this histology, with this drug, with these parameters, this is historically what happens. We should maybe start switching or something like that. I just think this is the important part, and that's why we wanted to have this discussion. Is we have to design trials around this, but we need a lot of upfront data, and that's going to take some time and effort, and all of us are going to start to work together on this. So, no, this is exciting. And you said this is a preprint, the Evolutionary Tumor Board?
Yeah, it's on medRxiv. Yes, Dr. Mark Robertson Tessie is the first author, and was really the engine behind it. Kind of a incredible person, really, that can kind of pull together a lot of disparate ideas and thoughts and make a really beautiful mathematical model out of it. And again, aligned with that same idea that while not a clinician, that there is a perfect decision that can be made by every patient given enough data.
Yeah, no, that's exciting, and I think it adds more rigor to all of our tumor boards. We do have a tumor board at SARC that we do have monthly. Dr. D'Amato, she runs it right now, and there's a lot of discussions on what to do when you get this point. And these are small numbers, but I think we have the strength of pulling all those together and in creating the data. And right now, they're, as you said, in all these different silos, and they're not even captured like data. They're just CT scans, which have data behind it, but we never mine it. So, or MR or functional imaging. So,
yes, absolutely. I think the limitation really is just organizing the data now. Because what I will say, having worked with many of the mathematicians, modelers, and all that stuff, is that they cannot be overwhelmed by data. Like, the more you give them, the better. They can take an MRI and say, "I'll look at every pixel." Like, let's analyze every pixel. And you're like, "Wow, how would you do that?" And they can't.
Yeah, and The same thing when we look at genetic data. It used to be 1 or 2 chromosomes, and now we're down to all these SNPs and everything. So we get the idea, and data is data. We can just feed it more, and you can never have enough.
Yes.
Let's switch here just as we kind of think about this a little bit. Is when you and I met, I remember it was I think it was in Hawaii, and I asked you to be a mentor for a young investigator because I felt your personality, your ability to be a good mentor to a young person going through sarcoma field, trying to develop their career, and without hesitating, you said yes. And now, for various reasons, it didn't work out and whatnot because it's crossing institutions and that. As you are in a leadership role now and have been in the past, how would you describe what is an ideal mentor? But more importantly, what is a good mentee? Because we are trying to be mentors, but sometimes what is it that makes a good mentee?
Yeah, I think that there are rules of the mentor-mentee relationship for sure. And so I'll try to outline it, but thank you for the kind words. I have benefited a ton from various mentors, and just real quickly, like Michael Nieder again, has been and I got the privilege of working with him the last 15 years as well, and Steve Lesnick has been a fantastic children's oncology group mentor. I look up to Richard Gorlick and Katie Janeway. Sherry Spunt was critical at St. Jude. Michael Dyer was a fantastic lab mentor and PI when I was training in postdoc as well. And then, of course, like Dan Sullivan, who taught me everything about trials at Moffitt, and Doug Letson has been the most tremendous career mentor and friend as well. And I mean, I'm lucky that way. So yeah, always a quick yes for others. And it is fun to mentor because, so I think what a mentor should do is like largely react to what the mentee is asking for and bringing, but then also anticipate the things that the mentee has no idea to even ask or consider. So I think a well-placed question towards the end of a meeting between a mentor and mentee to either expand what is going on or kind of suggest a direction is what a mentor really needs to do. Be open, honest, vulnerable, really be available for any kind of question is another part. I think most of it really falls on the mentee, though. The mentee has to be the engine, has to come with, here's what I need to get out of this. They have to schedule the meetings. They should come up with the agenda. They should be, show that fire. I need this from you, mentor. And they should be doing all that. I need your time. I'm going to be ready. I'm going to ask you some questions. I'm going to follow through on what you say and try things. I'm going to check back in. And if I run into another trouble, I'm going to reach out. I think from what I can tell through experience in the Children's Oncology Group and CTOS and other mentorship things programmatically and at different institutions, 90% of the time it fails because the mentee was too shy or didn't want to bother the mentor or something like that. And I think that that's how they fail. And I always do feel weird as a mentor reaching out to suggest to meet with a mentee. I feel like it's not ideal. But when I have done that, I've almost always found that the mentee was like, I was just so overwhelmed. And so it is a little bit not as black and white as I was saying, and every once in a while a mentor probably should check in, and maybe that's what happened with the experience with your mentee. But but that's what I would say are the main rules: the motor and the agenda for the mentee, and the mentor should be absolutely able to answer all those kind of questions and suggest when a direction, when not. Those would be the main things.
I picked up a couple of good things here, which kind of just rings in my mind here. One is always end with a question that maybe the mentee did not think about. You also said to be vulnerable, which is true. And the last one that I thought about that I think resonates is it's up to the mentee to establish the cadence. Hey, Dr. Reed, I had a good time and thanks for your questions. I'll set up a follow-up in 3 months or whatever you cadence. And that's the ownership of the mentee to do. And, the good thing is all sarcoma docs are really approachable. You'll learn different things, not the same things. You learn maybe not what to do, by doing certain mentors, but you also might learn things that you didn't think about. So I do think that having this mentorship role is important, and we're starting to get the turnover of a lot of staff that you and I grew up with that are getting close to retirement now. So I picked the brain of my mentor almost every day when I was in clinic, but now we have to pay back a little bit, and now it's not only at our institution, but maybe other institutions. And you're at a great place now. If people want to reach out to you for that through the Children in College Group, through CTOS, I think there are many valuable opportunities.
Yeah, very well said. Yes. And yeah, I definitely still rely a lot on my various mentors and go to them for different things. And the only thing I'll add on is that when I recently gave a talk about mentorship, mentee kind of things, the one thing I told the audience was that so much of what I've learned isn't from those older mentors or younger mentees, but my peers. And I said, I don't even know what to call this slide, but these are all the people that I have rapidly switched between being their mentee and mentor because they've crushed it on the clinical side, or with it, they developed a trial, or they had this research grant, but they needed help with this. And so there's all these peers, and I agree, the sarcoma community is so wonderful that way, where there's so many people that we grew up alongside and have learned so much from, and then they would say they learned from us. And I think that whatever we call that relationship is also part of this whole mentor-mentee thing to me.
It's almost a colleague thing and growing from each other. And this field is so big, so huge, as you said, and you started out with that, is going to CTOS and having basic science surgeons, radiation oncologists, medical oncologists, peds, AYA, imaging people there. So it's like there's no way in the world I can be an expert in any of this. So as long as we're humble, we're vulnerable, we can all learn. So this is great. Dr. Reed, thank you for spending time with us. Is there anything else that you want to make sure our audience knows about yourself, AYA, mentorship, and how to even think in the concept of Evolutionary Tumor Board?
I think I do worry a little bit that there's not always everyone interested in every single discipline in sarcoma. And I think, like for instance, very recently at CTOS, there was a couple people calling out, "Boy, we need more pathologists here." Let's say, for example, and so. And in pediatric oncology, there are people that have gone to industry and those sorts of things. So there is, I think, one of the best things about evolutionary oncology. I think one of the best things about saying this is a big problem and we need fresh ideas and lots of ideas and those sorts of things is that it does get the younger people excited. And I think that there are increasingly people that, I didn't study data science as a college student because I don't even know if data science existed then. Like, I don't even, I am no longer an AYA. And so so there is, I think, the idea that cancer is complex and we need fresh ideas, and we're not just one idea away, and building this kind of Big Ten thing is good for sarcoma writ large. And I think that's one of the other things is that we need even more disciplines to come to CTOS. And the theme next year for CTOS is indeed addressing heterogeneity. And I think that tumor heterogeneity is no good because it makes it more resistant and more likely to win out. Heterogeneity of the sarcoma community is a fantastic thing. And I'll give a little credit to Rebecca Gladdy for pointing that out to me too, is that we should be approaching sarcoma with all kinds of ideas and all kinds of heterogeneity so that we can get those best ideas to approach and anticipate cancer as it adapts to our therapy. And so I am optimistic about sarcoma outcomes overall. I'm optimistic about the technologies and the way we've split them down and are starting to really make progress. And I'm really looking forward to working with the team here and with all my colleagues around the world to make it better for the patients, for sure. And I've appreciated your collegiality and friendship over the years too, Scott. So this has been very nice. Thank you for letting me participate.
We do appreciate that. And as you said, tumor heterogeneity is bad. sarcoma heterogeneity is good. So let's just leave with that part there. And, I'm thinking that San Diego is not too far away, and you're probably working on this already, I can tell. So for CTOS, and maybe some of us that are listening to the podcast can start to think about how we start to study and design and bring more people into our fold, because you're right, when we learned computer, it was on a flip card, you put it through a machine and you had a punch in it. Well, I didn't grow up in data science, and there are a lot of people who do. So this is great, and I'm glad that you're at an institution that continues to strive for knowledge and understanding, and we look forward to great things while you're at Memorial, Damon. So very good. So Damon, thank you again for sharing your thoughts on the Evolutionary Tumor Board. The field of sarcoma research is expanding. The role of mentorship is going to be important, as we all know, and we look forward to further collaborations as we go along. So we do appreciate it. So thanks, Dr. Reed.
Thank you.
For those that are listening, we will continue on with our next podcast. So please subscribe so we can then get these messages out to you. So we look forward to a future time together in SARC Talk.
Thank you for listening. Be sure to subscribe so you never miss an episode of SARC Talk. To find out more about SARC, please visit our website at sarctrials.org. To suggest a topic or for questions, please email us at sarctalk@sarctrials.org. The SARC Talk series is made possible due to funding by Aadi Biosciences and Boehringer Ingelheim. Together, we can find a cure for all forms of sarcoma.